I'm Megan Gleanson. I'm also one of the sports medicine surgeons at ONS. I'm going to talk today about meniscus tears, which for a lot of people is a very, very common injury. Most people have either unfortunately dealt with this themselves or they know someone who has experienced a meniscus tear, but there's a wide range of types of tears. So that's what I'm going to go into a little bit of the types of tears, when you need surgery, when you don't, and some of the treatment outcomes. So we'll talk a little bit about the meniscus, the examination imaging we use for a better assessment, types of tears, and then management options, surgery, non-surgery, what we consider in different individuals, and then some of the outcomes that we look at with these treatments. So the knee, as Paul just went into in some detail, is a fairly complex structure. There's a lot going on in terms of bone, cartilage, ligament, different muscles. A lot of stability is important in the knee, but we also get a lot of motion out of the knee as well. So I'm going to specifically talk about the meniscus, which is both present medial and lateral within the knee. So it's crescent or wedge shaped, usually about 3 to 5 millimeters in thickness. It's actually very squishy and soft. It's primarily made up of water. The vascularization is a big issue that we talk about in terms of the meniscus and its healing potential. We'll go into a little bit more detail about that. But we have both a medial and lateral side. The medial is a little bit more C-shaped, whereas the lateral side is a little bit more U-shaped and kind of moves a little bit more. I often, when I talk to patients, they'll say, well, what do you mean I have a meniscus tear? What does that mean? And I'll often say, just out of simplicity, well, this is the bumper between the two bones within the knee, but it actually does so much more than that. It gives some stability to the joint, and it also is involved in proprioception, so it will help with motion and balance and ability to move in general. So it's not just a shock absorber or a bumper, but it has multiple roles. So talking a little bit more about the vascularity, and this is one of the issues that we have to take into consideration when we talk about different types of tears. The meniscus is vascularized from the periphery, this perimeniscal plexus or complex. If you look at the picture on the left, you're kind of seeing some of the vascularity. But as we look more toward the right side of that left picture, there's not a lot of blood flow going into the inner margin of the meniscus. And this causes some problems in terms of the meniscus's potential to heal. So we talk about it often in terms of the red and white zones, red meaning more vascularized and bloody, if you will, and white being more avascular. So when we have tears that are more on the inner periphery or that white zone, those really don't heal well. So when we see tears in that region, those are often not amenable to stitching or repair, whereas when we see tears that are more out toward the periphery or that red zone, those really actually do well because there is some healing potential out there. And this is one of the things that we struggle with the most when we deal with meniscal injuries. That red-white kind of interface is an area of a lot of discussion and controversy about when do you fix them and when do you trim them. So I heard a pop in my knee. That's one of the most common things we're going to hear coming into the office. It's the dreaded noise. So, as I said before, this is one of the most common injuries we see within the knee. It is more common in people, as Paul had mentioned, who are ACL deficient because of instability. Often see tears on the medial side more than the lateral. In a younger athletic patient, we may see a traumatic tear, and oftentimes it's in the periphery, often associated with other ligamentous injuries like an ACL, cartilage, other problems. In an older patient population, oftentimes we'll talk more about a degenerative tear. This is not universal. We have older people with acute injuries, and we have younger people that may have more of a degenerative picture for various reasons, but generally speaking, when someone comes in, I'm going to think about my 16-year-old versus my 57-year-old a little bit differently. So in the older patient population, especially when we're thinking about more of a degenerative tear, it usually isn't something that happened acutely. Maybe it's been something that's developing over time, and we also have to think about the associated structures of the knee. There's also another category that we refer to as meniscal root tears. I'm not going to get into that in great detail today, but that is something that we are often leaning toward fixing for more stability, but that's kind of a separate category. So I'm going to kind of focus just a little bit on our acute versus our degenerative tears today. So an acute tear, think about it as that classic pop. Associated joint line tenderness, so they'll come in and say the inside of my knee is killing me, I was doing something, I felt a pop, knee swells up, trouble with range of motion. That's kind of one of the common things we'll see in the office. I'll also see other patients who will come in and say, I was not doing anything really out of the ordinary, I was cleaning my house this weekend, I was doing a lot of yard work, and the inside of my knee is killing and it's a little bit swollen, and I don't remember anything happening, but I'm just having a ton of pain. So when we examine them, we're often looking at, the location of the tenderness, swelling or an effusion, whether that's present or not. And then oftentimes we'll talk about something called mechanical symptoms, and that's whether they're getting clicking, catching, as we go through a range of motion, are they feeling something kind of shift in there. So these are all really important things from the physical exam standpoint. So I look at joint line tenderness, and I'll document that, as well as discomfort with a hyperflexion maneuver. A McMurray's test is where we go into hyperflexion and then some rotation through the tibia, and oftentimes that'll give a clue as to whether or not the meniscus is affected. A bounce test is where you kind of let the leg kind of literally bounce in extension to hyperextension. Sometimes that can also be uncomfortable in this patient population. And then the motion. What we talk about as more of an urgency or an emergency in sports medicine is when a knee becomes locked, and I'll show you some images of what that could represent. But that's where we can't get any motion out of the knee, and that's something we don't really want to sit on or wait. So if anyone sees a patient who, especially a younger person who cannot move the knee, cannot get extension or flexion past a certain point, we worry a little bit more about meniscal involvement physically blocking the joint. So x-rays, we're almost always going to get an x-ray. We're not going to see the meniscus, but it does give us some information about the knee in general. So oftentimes that's a great place to start. So even if you all are seeing your own patients and not sure what's going on, there's no harm in getting an x-ray just to know, are there little avulsions, kind of like what Paul talked about with the Sagan fracture? Is there arthritis? What are we dealing with? But the next step and most valuable step is going to be an MRI, and that's where we're really going to see more detail about the meniscus. It also obviously shows us information about the cartilage, ligaments, other injuries that may be going on. A CT arthrogram is not commonly used, but it is an option if a patient can't have an MRI. So what we're seeing on the left side is an axial view of a knee, and there's a radial tear. You can see where that white arrow is. There's a disconnect between the rim of that round kind of C-shaped meniscus, and that's one type of tear. On the other side is a horizontal tear of the medial meniscus, and you can see that little white line, well, again, right by that arrow that shows a separation. That little triangle where the meniscus is sitting should be just a solid black area. You're seeing that white fluid infiltrate. So when we talk about meniscus tears, we're going to classify them. We want to know if they're medial lateral, acute versus degenerative. Sometimes that's not always obvious, but we try to get a better sense of whether it's been there for a while or if it's something new. The tear configuration, that is something I always think about in terms of, can this be fixed and how will I fix it? Is it complex? Is it horizontal, longitudinal, radial, flaps, roots, all types of things that we're going to look at on the MRI. And then again, going back to that picture about the vascularity, is it in the periphery? Is it in the inner margin? Where is it and how well will it heal? And then are there other injuries going on? Do you have an ACL tear? Is there a big chunk of cartilage missing? What else do we have to take into consideration? So these are some examples of types of meniscal tears: radial, vertical, horizontal, all types. This is the dreaded bucket handle. It's where the meniscus tears and flips over, and this is something that can lock the knee. So if this is something you're worried about in a patient that you're treating, obviously this is something you don't want to wait very long on. So non-operative management is usually done for small, stable tears or shallow tears. Tears that may heal well on their own without intervention. And then the other time that we often think about non-operative management, and this is, I think, an important point, is people who are arthritic but have meniscus tears, we don't go in and necessarily operate on those. I don't want to say universally we do or we don't, but generally speaking, in the setting of arthritis, it's not favorable to go in and trim up those meniscuses. The days of doing a clean out or scraping up cartilage, things that patients have told me before, people really don't do well with those, and we're really getting away from that treatment. So you can ice, you can heat, you can take Tylenol, corticosteroid injections, HA injections, bracing is sometimes helpful. Physical therapy is often very helpful for these patients. So you can try icing, that's always helpful. This is my niece who likes to go around daycare and inject everybody's knees. I could not be more proud, but injections are often very helpful for settling this things down. But sometimes we do have to talk about surgery. The two things I'm going to focus on today are partial meniscectomy, or just trimming the meniscus, as well as meniscal repair. There are some other situations where we'll have to do meniscal transplants or we'll augment repairs, but we're just going to focus kind of on the two most straightforward, most common meniscal treatments. So partial meniscectomy for the inner margins, that white zone I talked about, or like leaflet tears, those horizontal tears. The problem with doing a meniscectomy is why not just go in and trim everybody up? Is as we take away that shock absorber, that bumper, we increase the contact pressure, which then puts people at risk for developing arthritis. So on the lateral side, you can increase the contact pressure by up to 75%. We worry about that progression into osteoarthritis. I will very commonly see people who come in with that kind of degenerative picture that said, oh, I had a meniscus tear 20 years ago and I had it treated and I've never had a problem since. I get an x-ray, that joint line is closed down and they've developed arthritis. So we want to be very judicious in terms of how much meniscus we trim, treating it appropriately, taking care of the pain, but not just hacking it out, because if we remove too much of that meniscus, we do run into some trouble. Meniscal repair, if we can, is obviously the favorable way to treat, and that's obviously a little bit more debatable in terms of when it's appropriate and if it's going to heal. So that red-red or red-white zone, we often talk about improvement in meniscal healing when there's done with another surgery like an ACL, and that's often because there's a lot of bleeding and biologic elements in the knee, and the meniscus may heal a little bit better. And there's a lot of different techniques we can use to stitch that meniscus back down. We can use some all-inside techniques, so it's still minimally invasive, but there are certain situations where we do have to do a little bit more surgery, and that can lead to scarring and some other limitations. But when possible, we do try to repair the meniscus. Unfortunately, not all of them are amenable to that. So just talking about some data in terms of overall improvements at 2 years follow-up and trying to stay within the vascular zones. Unfortunately, there is a slightly higher rate of failure of meniscal repairs, and sometimes there is the need to go back in and do a second surgery to address the unhealed portion of the repair. So who's going to get surgery? That's the big question. 18-year-old with a twisting injury in a locked knee, this is a bucket handle. That you want to get to as quickly as possible. You want to try to reduce it and stitch it back in, so that's going to be a repair. 25-year-old female, twisting injury, lateral knee pain. This is an example of a radial tear. Same thing, we want to get in there as quickly as possible, stitch it back in, try to stabilize it so it doesn't propagate, and we don't have to take out a significant portion of the meniscus in a young person. 58-year-old male, knee pain on the medial joint line, no specific injury. We see arthritis, but we also see meniscal injury. A lot of times we'll try to leave these alone if possible. Some of them do end up needing to have it trimmed if they have persistent symptoms. With the initial treatment, we're going to try to treat without surgery. So partial meniscectomy, people do well initially. They get up, they get moving, there's not a lot of downtime, but we worry about, again, that development of arthritis. The average that we talk about is somewhere between 8 and 16 years after the procedure. And then, worrying about, again, needing to move to something like an arthroplasty if we're doing a procedure like this in a patient who already has arthritis. Meniscuses do heal better when they're done with other surgeries, and they tend to really not heal well if you're doing it in an unstable knee. There, again, as I mentioned before, there's an increased rate of reoperation if the meniscus doesn't heal, but a lot of times we'll try it, especially in a younger population. So, symptomatic arthritis. If we go in and trim up the meniscus, we're worried that they're going to need a total knee sooner rather than later. Degenerative tears are better treated with meniscectomies, only because they've usually been around for a while. Post-op physical therapy or a home exercise program is key. A lot of people will do better with that kind of treatment. And repair, when possible, we want to do over a meniscectomy to try to preserve the joint.